rates within just the first last 3 weeks alone. So it jumped from only 1% to over 30%, and this also what's happening now in our country. Okay. The other concern here is that because of its high transmissibility, then this virus also display a very high advantage over that of Delta in terms of growth rate, growth advantage. And we see a lot of cases now that in the household, we have a higher number of household transmission, number of cases in the community, and also in the workplaces. No, and these are just an indication of how high the attack rate, okay, the secondary attack rate, and which substantially increases the growth rate of this number of cases that we have experienced now. And these are some of the possible reasons why increased transmissibility and also in evasion from the antibody that we have from vaccines or natural infection, and why also we have higher reinfection. So we noticed that there are those who were infected last year with COVID, and still again another infection again with this new with this year. So that's a sign of a reinfection, and most likely that's again an Omicron variant. Now we go to the symptoms. In the initial data coming from different countries like South Africa, United Kingdom, Canada, and Denmark, it indicated that most of those admitted are having mild symptoms. Okay, and in fact, they always indicated that their risk of hospitalization, the rate of hospitalization was really lower compared to Delta. Okay? But I would like to warn you about this, because we need additional data from other countries to understand the relationship between Omicron and clinical severity. And when you talk about severity, those patients who are on oxygen, those who are mechanically ventilated, and of course, that is an important parameter of severity. So most of this data are telling us that compared to Delta, lower risk of death, lower risk of severity, but we always have to observe, we always have to monitor, because it may not be necessarily the same as that with other countries. And that's the reason why we need to observe also our data. This is a South African data also that they have indicated that in their Omicron surge, there were 73% less likely to have severe disease. No? So the proportion of those admitted, the proportion of those on oxygen, and those with severe manifestation and death is quite low when you compare Omicron to that of Delta and Beta in their data in South Africa. And that was also the data coming from UK. And it seemed that the alarm in terms of severity is not as fatal as that with the Delta variant. There was data that it can only cause substantial, not a very high rate of hospitalization. And at the same time, this observation was a bit a good news to hear, no? Because the potential for overwhelming capacity in the hospital will always be our problem, especially in our setting, wherein when we have much of these cases, and based on our experience also with the Delta variant. So just to explicitly mention some of this important data, like in Europe, okay, the risk of emergency department attendance was really lower, 15 to 25% lower among those who had Omicron compared to Delta. So the comparison here is always with Delta. And then the risk of hospitalization is almost 50% lower compared to Delta. And for those who had previous infection, in which we know that they already have antibodies and at the same time they are vaccinated, then there is also further reduction of the risk of hospitalization. So mas maliit ang maging hospitalized if you were previously infected and you were vaccinated. And that was also experienced in UK. Only like 0 to 30% were admitted with those who had previous infection. And in Scotland, it's also 55 to 70%. Okay, so what are the symptoms of Omicron? Are they different in any way with the other variants of concern? Okay, so as with all other SARS-CoV-2 variants, early data indicate that the severity of Omicron increases with age. So this is what we meant, that if you are a vulnerable population, especially those with underlying medical conditions like diabetes, hypertension, or immunocompromise, then risk of severity will always be higher. And particularly, I would like to emphasize this in people who are not vaccinated. Okay, so it seems that all of this data are really they indicate the protection that we have with vaccination. So more or less, most of the data are telling us that it will typically present with mild symptoms, especially if you're fully vaccinated, and more or less if you have received your booster vaccine. But unvaccinated individuals may still experience quite severe symptoms, which may require hospitalization or death. Now, what is the impact now of this Omicron variant being highly transmissible and less ability to cause severe disease? Is there something that has changed in terms of the ability of the host to accommodate this virus and more replication, or are there problems with fitness of the virus that it cannot penetrate the lungs and other deeper tissues compared to the Delta that somehow contributed to the pathogenicity of this virus? So there are evidence that there is a shift in tropism towards the upper respiratory tract. So tropism meaning the virus is indicated that it highly attached itself to the upper respiratory tract compared to the lower respiratory tract. And these are partly some reason why most patients present with an upper respiratory tract infection like sore throat, cough, and body malaise. Now, and there was also evidence of less severe pathogenicity. So they did a lot of these animal studies and found out that the load of the virus in the lungs is really lower compared to those in the upper respiratory tract. The first among these to give us the information, an important information that this could be one of the reasons why it will present with less severe infection or less severe manifestation, are these scientists coming from Hong Kong, wherein they did in vitro study on inoculating the virus, okay, on human lungs and bronchus. Okay? And they found out that the Omicron virus, in fact, can multiply 70 times faster than the Delta variant in the human bronchus. Okay, so this is how high the number of the viral load with Omicron compared to the Delta. And this explains why Omicron may transmit faster between humans than previous variants, because it is highly large. The enormous number of the virus is in our upper respiratory tract. And when we cough out, when we sneeze, or even with speaking, then that you will always realize that you are also aerosolizing and letting the virus airborne. And that's where you can get the infection. And compared to the lungs, wherein they compared it with the Delta variant, they significantly found out that the viral load, okay, of the Omicron virus is 10 times lower, in fact, than the original strain and that of the Delta. So this explained possibly why in most patients, particularly the young population, the younger population, the healthy population, are only manifesting with an upper respiratory tract infection. Then additional studies from these different authors, most of these are preprint, wherein they look at the concentration of the virus in the lungs and in the upper respiratory tract. And all of these studies indicated, whether it's a human study or most of them are animal studies, indicated that there is really a reduced level of the virus in the lung tissue. Okay, it is less successful to infect the lungs and replicates more rapidly. So meaning it multiplies rapidly in the upper airways than in the lungs. Okay, so we go to the vaccine. Are the current COVID-19 vaccines effective in protecting against Omicron? Okay, so preliminary data from multiple studies indicated that individuals who have received a primary vaccination series or who have had prior infection have lower neutralizing antibody titers against Omicron. No? And this is understandable because of the number of mutations wherein it will not be able to be detected by our own antibody that were produced by vaccine, including those who had prior infection, then that would indicate that the neutralizing antibody titers, if tested against this Omicron variant and you receive all of those vaccine, it is expected that this will be very low. And you know that neutralizing antibody are the antibodies that protects our cells against the virus. So there was increased risk of reinfection in most of these countries. And at the same time, there's also, because of the evasion of the virus towards the antibody that we produce with the primary vaccination. So just an example of some of the data coming from UK, wherein they compared the vaccine effectiveness, no, in those with Delta and that of the Omicron variant. Okay, and you'll notice that here the dark one is Delta, and then this is Omicron. So if you receive 2 doses of your AstraZeneca vaccine, you are well protected with your against Delta. But here in this data with Omicron variant, it will really cause decrease in the effectiveness, no, as low as 20%, and even in fact 0% if you had Omicron. And when they gave a booster shot, okay, in the form of a Pfizer or a Moderna, 2 to 4 weeks after, okay, the neutralizing antibody, the protection has been retained, and protection has increased from as low as 0 to 60%. And then this is with Pfizer booster dose, and then this is also with Moderna booster dose, wherein it elicited a higher effectiveness compared to Pfizer. But again, both of these are effective as a booster dose. And then for those also who receive Pfizer vaccine in their data, that when they look at and compared it with Delta and Omicron, there is also drastic decrease in the effectiveness of a 2-dose of your Pfizer vaccine. And that when they give the booster protection shoot up within a week after giving the booster dose. This is the Pfizer booster dose, and this is the Moderna booster dose. Okay, so that's the data, and this data only indicated that up to 10 weeks there is a very good protection. No? 10 weeks after receiving the booster, there's still a good protection against this Omicron variant. Okay, so a lot of this data are coming that all of these vaccines, no, particularly the mRNA vaccine, the Janssen vaccine, the AstraZeneca vaccine, protect us against an Omicron variant, and an additional dose, okay, will somehow retain its efficacy, effectiveness, and to be protected, particularly in the development of symptomatic disease, more severe type of infection. Okay, so when they look at this, yes, we can still be infected because of the possibility of an Omicron variant evading our antibody, our immune response that we elicited from vaccine. But the risk again, no, the risk of getting the severe disease is less likely, especially if you get the booster dose with any of these vaccines. So this is the importance why we need to get the booster dose for us to be protected against severe disease. And compilation of several of this data, particularly in this data come from UK, that the risk of hospitalization is lower for those who had Omicron cases after 2 and 3rd doses of the vaccine, with an 81%, no? So range of 77 to 85% reduction in the risk of hospitalization after 3 doses compared to an unvaccinated Omicron case. So you can see the advantage, no? The enormous advantage of being vaccinated over that of an unvaccinated individual. So just to give you some snapshot of how also the vaccine expert panel collated some of this data, wherein we look at some of this, most of this published article, that Omicron variant really or significantly reduced the neutralizing antibody and giving a third dose, okay, retained the protection in most of this vaccine. And this is the primary basis why the government, okay, has indicated and recommended the use of a booster instead of a 6 months interval from the last dose. We have shortened the interval to 3 months, no, in order to get an early protection, because we predicted that with the surge of cases this January, February, when we started the booster doses in late part of November and December, then chances of high likelihood that we will still be protected against severe disease will be an important part of the program. Okay, so all of this vaccine elicited a very good neutralizing antibody with the third dose, and it seemed that as of this moment, the third dose will still work against the Omicron variant. And although there are some uncertainties in terms of how long will the duration of protection against hospitalization with this Omicron variant, and which until now we don't know yet, no? But we expect that it will be longer, because there is this other part of your vaccine, which is your T cell, in which there are new data now that it is the one responsible that protect us from severe infection, and your T cell response is also longer, and that's why it can protect us longer also against severe infection. So the key messages with vaccination is that we need to increase our vaccination rate, our coverage, and we need to focus also on high-risk population, especially the 60 years old and above, and those with comorbidities, and particularly those who are immunocompromised, wherein protection should always be given and should be maintained in order for them not to develop the more severe infection. And according to the SAG or SAGE review, the primary objective of booster doses is really to maintain and optimize vaccine effectiveness against severe disease outcomes, particularly in a population that are at high risk of developing serious disease. Now, the other important question here is that probably you've heard that there are those who said that the antigen test or the RT-PCR cannot detect an Omicron variant infection. So Omicron appears to have no effect on the diagnostic accuracy of routinely used PCR and even antigen detection rapid diagnostic test assay. So we're still comfortable with the way we are doing our tests using our RT-PCR and the DOH-approved rapid antigen tests. Now, I'll segue with the current treatment now, because one important part of controlling the pandemic is also treating those high-risk population. So meaning those high-risk population that when they develop COVID, they are also higher risk to develop the more severe COVID and higher risk of mortality, okay? So there are preliminary data that there are some therapeutic interventions that still are effective against COVID-19, but there are also therapeutic interventions that have been known to be reduced by the Omicron variant. And we're talking here of some of these are your monoclonal antibodies. No? Okay, so I made here a graph in terms of how we are doing now and how are we treating our patients with COVID-19. Okay, I got this from the DOH circular, which was released January 6, 2022, part of the annex. And this is also the as a result of the living guideline guideline from the PSMID. So in that treatment guidelines, okay, there are two aspects of treatment: treating those outpatient or non-hospitalized and treating those who are hospitalized. So we'll take first the outpatient. So in that review, in that guideline, okay, there are interventions that can be given upon those who are exposed to a confirmed case, and in order for you to not to develop the infection. And particularly, these are given to high-risk population with the use of your monoclonal antibodies, casirivimab and imdevimab. Now, for those who have mild to moderate symptoms, it also indicated that there is a role for your monoclonal antibodies, particularly with your casirivimab and imdevimab, bamlanivimab, and your etesivimab. And of course, you have your oral antivirals, your molnupiravir, and this new antiviral drug, the nirmatrelvir-ritonavir combination, which just got the CSP approval from the Philippine FDA. So when you look at also inpatient, the same regimen we're giving, remdesivir, tocilizumab, baricitinib, these are anti-inflammatory agent to decrease the inflammation and decrease the risk of mechanical ventilation. Steroids is part of that, and including prophylactic anticoagulation. Okay, I would just like to show you here the problem now with current monoclonal antibodies. Okay, and this is coming from the FDA data. So both these monoclonal antibodies, your Ronapreve, no? So this is the generic, the name of casirivimab and imdivimab here in the Philippines. Now it's Ronapreve, and found out that when they look at the mutations of the Omicron variant and tested the monoclonal antibodies using a pseudotype virus-like particle neutralization assay, they found out that the susceptibility of the Omicron variant is reduced with your casirivimab, no? So meaning your casirivimab and imdivimab is not able to neutralize the Omicron variant, which is like 1,013-fold reduction in susceptibility of the Omicron variant with this type of monoclonal antibodies. With regards to the other monoclonal antibodies, your bamlanivimab and etesivimab, it has a higher reduction in susceptibility, which is 2,938-fold. So these are indicators that both of these monoclonal antibodies may not work in a patient who has an Omicron variant infection. And we need to monitor, particularly those who have been given these antibodies. And moving forward, if we are going to recommend this at this point in time where we don't know yet if Omicron is the one infecting an individual, and then most likely during the surge, if one is given this monoclonal antibodies, how one will be protected. So in the outpatient therapeutics also, aside from that, no, so they look at some of these therapeutics or treatment that are still effective even against Omicron variant. No? So one of that is a new monoclonal antibodies. We call it sotrovimab, okay? And still active against your Omicron variant. And for the other therapeutics, data from cell cultures that the following drugs still has a preserved activity against Omicron. So meaning still active against the Omicron variant, no? So you have your nirmatrelvir, ritonavir combination, then your molnupiravir, and that of your remdesivir, still active against this variant of concern. So here is a table how these outpatient therapies stack up in terms of efficacy. So ranking them to the most effective to the least effective, you have here the nirmatrelvir, ritonavir combination with the relative risk reduction of hospitalization and death, 88%, okay? Highly efficacious against the Omicron variant. This is an oral regimen, a 5-day oral regimen. And the only downside here is that because of the presence of ritonavir, then you need to know the drug-to-drug interactions because it can also affect the concentration of other drugs that will be given together with this drug. Then this is followed by a monoclonal antibody in the form of sotrovimab, wherein it can also reduce the risk of hospitalization and death in 85% based on their clinical trial. So this is also a highly efficacious monoclonal antibodies and typically safe also in pregnancy with few drug-to-drug interactions. It requires an IV infusion. Okay, it comes in a 500 milligram, 1 hour observation while being infused in the hospital. Of course, the new data on remdesivir, why it can be given as an outpatient, especially for mild to moderate, wherein they look at the administration of remdesivir among placebo plus study arm, a total of 500 patients. And they found out that it was able to reduce hospitalization among those who were given remdesivir in 87%, okay? So it is still effective against Omicron variant, and at the same time with few drug-to-drug interactions. The only problem here is that you need to admit or you need to infuse the drug in the hospital setting for you to observe the patient. And of course, the fourth one is the antiviral drug, molnupiravir, based on their data in which the Move Out trial indicated that it can reduce reduction or it reduces hospitalization and death among those high-risk patients, no, like patients who have diabetes, those with coronary artery disease or hypertension, or even malignancy, that it can reduce hospitalization. The advantage here is it's an oral regimen and less of the drug-to-drug interactions compared to your nirmatrelvir-ritonavir combination, although it has lower efficacy compared to the other regimen, and there are also concerns of mutagenicity. So this drug is not recommended in 18 years old and below, not also recommended in pregnancy, not recommended among those individuals who plans to be pregnant in the next 5 days by which this drug will be taken, okay? So these are some of the table that I would like to emphasize for you to easily understand the efficacy, the ease of delivery. So ease of delivery, when we say it's taken orally compared to an IV infusion. So this is the advantage of your nirmatrelvir over that of sotrovimab and remdesivir, and also advantage of your molnupiravir. Less of drug-to-drug interactions with sotrovimab, remdesivir, and molnupiravir, and safety during pregnancy. All of them are safe except for molnupiravir, and all of them can be given in children up to more than 12 years old or those weighing more than 40 kilograms, except for molnupiravir. Okay, so timing is very important, no? Because these are antivirals and monoclonal antibodies, and it should be given within 5 to 7 days onset of symptoms. For example, your nirmatrelvir-ritonavir combination, it should be given within 5 days of symptom onset. Your monoclonal antibody should be given within 10 days of symptom onset. Remdesivir should be given within 7 days of symptom onset, and molnupiravir should also be given within 5 days of symptom onset. So 3 things we need to do urgently, as of this point. Vaccination, okay, that's the important part here. We need to protect ourselves, particularly severe infection, where vaccination has been proven that it can protect us against severe infection. We prevent further infection by following the health protocol, and at the same time progression to severe disease by those outpatient treatment to lessen the number of patients being brought to the hospital for severe infection. And more or less, this is the most important, prepare our health system for the coming surge of cases. And I think we have seen some hospitals now are almost full, and these are important things that we need to know. And based on the DOH reminders on mitigation strategies, there are 3 of those that were emphasized. One is strengthening the health response and capacity needed to prepare for possible community transmission. And what are these? Offering services for telemedicine, especially for those that doesn't need hospitalization. And then in the hospital side, there should be inventory and supply of medicines and oxygen tanks, and also preparedness of the hospital and ICU facilities. Second is the vaccination, including booster, is essential for added protection. So it can be mild, Omicron may be mild, but can be severe in unvaccinated, vulnerable population. And that's why the important priority for a booster are those vulnerable population, the A2 and the A3. And of course, to the public, continued diligence in mask wearing, hand washing, distancing, and ventilation remains very critical to stop the transmission. And once you are symptomatic, as much as possible, you have to isolate. First thing you need to do is isolate yourself, okay, and observe also those nearby in your household who may have symptoms, okay? So these are important messages, and I think that's my last slide. And I would like to thank and acknowledge some of those who helped me in these slides, Dr. Edu Vasdi and Dr. Jocelyn Segurit. Thank you very much for your kind attention.
Thank you, Dr. Solante, for that very informative and updated lecture regarding COVID-19 and the Omicron variant. So, sir, overflowing na po ang ating chat box for Q&A. So, sir, ang first question po na gustong sagutin is, thank you, sir, for this very useful update. Aside from the monoclonal antibodies, are there data showing that the effect of other treatments like antivirals of the Omicron variant? Thank you very much. I think, sir, top na lecture nyo, baka gusto lang ma-emphasize.
Yeah, so the drug that we're looking at with a very high efficacy is your nirmatrelvir, no, and ritonavir combination, which has 88% reduction in the risk of hospitalization. And the other one, of course, is your molnupiravir and that of your remdesivir.
Okay, sir. May two questions, sir. Ano ka na lang? Pagsamahin ko lang kasi related. After an Omicron COVID, siguro ang ibig niya sabihin na dito, meron pa ba daw siguro another variant that will cause a long COVID? And ang second follow-up question is, what is your take regarding the Omicron being the beginning of the end of the pandemic? Kasi sir, di ba sa social media, may mga lumabas kung ganyan na it's the beginning of the end of the pandemic.
Well, it's quite a tricky statement, no? Because if you look at the data, as long as there will be no more mutations, okay, that will still be highly transmissible, then hopefully with this would be the last, no? But we don't know yet, because as long as there is transmission, and as long as there is the ability of this virus to lodge in our host cell, particularly the immunocompromised individual, no? The experience before was that most of those mutations are found in immunocompromised individual, especially HIV and those who have cancer. And this can be an important pool of mutations. That's why we need to prioritize protecting this population, because the next variant of concern will also be in this group of individual. And likely, in third world countries, wherein vaccination rate or number of vaccinated population are still low, then we would expect that this will be the area, the setting where another variant of concern will evolve, will emerge because of low vaccination rate.
Another question, sir. Do you see a parallelism in the situation of the Philippines and South Africa? Do you see the possibility that the cases will go down in a few weeks based on the data from South Africa?
Yeah, on that note, so we need to know the number of cases in terms of the uptick and the downtrend will always be dependent on the number of the vulnerable population. Okay, so in the Philippines, I would say, like for example, the center now of infection, of transmission of your Omicron is in the National Capital Region, and we have also a very high rate of vaccination already. And most of those who develop Omicron, I would say, are less severe, okay, with some of them manifesting only less than 5 days. So the uptick in the cases will depend on this population. And yes, I think it will be something like less number of days compared to the Delta variant, where we have really a long number of days wherein we had the number of cases almost 2 months, no? So I would hope, based on those information, and at the same time, if most of the cases are only mild, okay, then you only have a shorter duration of the symptoms, then chances are there will be faster decrease in the number of cases also.
Okay, sir, thank you. What is the stand of DOH regarding the RT-PCR as a diagnostic test, because it cannot distinguish between COVID and flu?
For now, RT-PCR is still the gold standard for the confirmation of COVID-19. So we don't have any statement yet on that. No, it's important to note that RT-PCR is still sensitive and specific for that. Okay, and it will remain as the gold standard for the confirmatory tests for COVID-19.
Sir, ang question regarding side effect. How can you differentiate if the rash is due to COVID or due to molnupiravir if the non-pruritic rash developed on the 7th day of COVID and on the 4th day of molnupiravir?
Okay, so rashes is also common, but not as very common in patients with COVID-19. And usually it also occurred during the viral phase of the infection, just like any viral. But if you look at the data, rashes is very uncommon also for molnupiravir. So if you have rashes after, so probably this patient has been given molnupiravir, and after 5 days, the patient still developed rashes. You just have to observe and quite difficult if that is because of the molnupiravir or because of the COVID-19. But we know that when you're giving your molnupiravir based on data, there is significant reduction of the viral load starting at 3 days and on the 5th day of giving it. No, so if rashes develop on the 7th day, most likely it's not COVID, but most likely it can be still secondary to your drug.
The drug, sir. Ito, sir, malas na question to. Ano daw po ang stand regarding the risk of transmission of a patient who is positive asymptomatic and a positive presymptomatic? Paano daw,
So
sir?
let's take it this now. So whether you are vaccinated or fully vaccinated and you have COVID, okay, your risk of the viral load starts to increase at least 24 to 48 hours prior to the appearance of the symptoms and the first 3 days of the first appearance of the symptoms. Okay, so that's the most important part, understanding the infectivity, how infectious the patient is. First 48 hours before the appearance of the symptoms and 3 days onset of the symptoms. As they go on with the symptom, 4th, 5th day, it starts to go down. Okay, and there are data to indicate that those vaccinated, have higher the antibody, the viral load are rapid to decrease compared to those unvaccinated. So that's why when you are implementing the isolation and the quarantine, longer quarantine for those not vaccinated and shorter quarantine for those fully vaccinated.
Sir, in relation to that, may tanong, meron daw radio interview with the cardiologist na ano daw po, nagtaas ang transmission because of the confidence of the vaccinated na pre-asymptomatic or asymptomatic.
Okay, so let's take that now in the context that when you are vaccinated, okay, so you have that protection, but that protection may not be enough to protect you against getting the infection. Okay, so that's why when the data is telling us there is always a higher risk of reinfection with the Omicron variant and that compared to the Delta. And because of the ability of this virus to evade the antibody that we produce with vaccine. Okay, so on that note, we are still confident that despite that, when you are infected, you develop mild disease because you are fully vaccinated. Second, the importance of getting the vaccine is really on getting the severe infection. So if you are fully vaccinated, fully boosted, then your risk of not getting hospitalized, not getting the severe form will be higher compared to an unvaccinated. But your risk of transmitting the infection when you are in that period of being infected is still the same as that with an unvaccinated.
Sir, yun nga, medyo akala ng mga tao, hindi sila nakakahawa pag vaccinated. So sir, ito pa po, maraming tanong about flurona. Ano daw po ang thoughts niyo about flurona?
Okay, so I think this is a combination of the influenza and the coronavirus, no? So I would like to just give you a trivia, no? The first case that we had, the first Chinese national case of COVID-19, was co-infected with COVID and influenza. Okay, and in fact, that's something that's not ordinary or not common, no? Because during this time, especially during the time that you also have a high flu peak season, November, December, you also need to realize that there's also a possibility that when there is a high COVID and a high peak flu season, then there is a possibility that there will be co-infection of the two viruses. So that in itself is a possibility, and in fact, it can also be possible here in the Philippines.
Sir, marami ring question. Ano daw po ang take nyo about Sinovac vaccine? Kasi sir, di ba maraming Sinovac ang primary series. So meron din po ba daw protection against this?
Yeah. So let's take this now, because in our recommendation, for those who were given primary vaccine series, and that's the reason why those who receive Sinovac, the recommendation is to get an mRNA vaccine or an AstraZeneca vaccine, because of the higher neutralizing antibody. But in the data, even with a third dose of your Sinovac, there's still an amount of protection, maybe less compared to an mRNA or an AstraZeneca, but there's still protection. But there is this small group of population that in which they they are mRNA is contraindicated. No? So for example, if you have severe allergic reaction to the component of an mRNA or an AstraZeneca, then a third dose of your Sinovac can still be protective. But again, the option is there. We laid the table that if you want higher protection, it's with your mRNA or your AstraZeneca over that of a third dose of your Sinovac.
Sir, may isa pang tanong. Ito na po ba yung peak ng ating surge? Also, is this just a beginning?
Okay, I don't know, no? Probably not yet, no? So we will monitor in the next 5 days will be very crucial if there will be an uptrend. So if there will still be uptrend of the cases, then we would expect that the peak has not yet, we are not yet at the peak of this Omicron variant-driven surge.
Sir, about it, the Omicron variant being an airborne. Yung mga ganun daw po, na airborne na daw.
Yeah, I think the data is already it has already indicated. No, it can be airborne, it can be aerosolized. Okay, so that's why when you are in an enclosed space, no, the emphasis here is if you are in an enclosed space with poor ventilation, you're higher risk of aerosolization, higher risk of airborne. The virus can stay in an enclosed space without ventilation for I think 6 hours. No? So that's how high, that's how long. And that's where we need to optimize your protection, not taking off your mask, not taking off your face shield. And at the same time, if you can have proper ventilation in those areas, that will be an important part of decreasing the airborne capacity of this virus and less of the transmission.
Sir, mayroon po akong mga pinagsama-sama na lang tanong. Ang majority ang tanong, ano daw po ang comment nyo sa policy ng DOH regarding the new guidelines for the quarantine period of the healthcare workers?
Okay, so let's take it first. No, why is it being recommended? No, so that is recommended in a setting wherein you have an overwhelmed number of cases in your hospital, and your number of healthcare workers are already very low because they are sick. Okay. So meaning you cannot cope up. The healthcare worker staff cannot cope up. So in times of what we call that's part of the contingency plan. So meaning you have that plan, okay, that in case that this is the number of cases and we need to back up the number of healthcare workers to remain our function as a referral hospital, then we need to shorten the isolation and the quarantine. And that is not only that, no, because when you will be put back to work, we should be sure that you are asymptomatic. You don't have symptoms anymore. Second, you will also be monitored that you will always wear your face mask, your face shield, okay, and physical distance. And then number 3, very important, while you are also working, you will also be monitored. So there are what we call safety nets, now riders in that recommendation. And this is only in areas where the number of healthcare workers is really low and you have an overwhelming number of patients to take care of.
Okay. So sir, ano yan? Policy, guideline, pero still up to the hospital or the clinic to really implement. Ang primary pa rin, sir, is to prevent the further spread of infection.
Yes, that's the order of we need to protect our healthcare workers. Ganun naman talaga yan no? And at the same time, we need to make sure that when they will be going back to work, they will also be protected, not only the healthcare workers, but also the patient that we're taking care of.
Okay. Sir, I know may few minutes na lang tayo, but there are many questions. Isama-sama ko na lang, sir. Yung question na common na lumalabas sa chat box, ano daw ang comment sa mga pasyenteng hindi na lang po nagpapaswab, pero symptomatic. Tapos ang isa pang question is, yun nga po, symptomatic ka na, sa kagustuhan mong magpaswab, sumasakay pa daw po ng public transportation.
Yeah, that's the problem. No? That's why we need to educate our patients, no, the public, that if you are symptomatic at this point in time where there is really high transmission of the infection, we know that once you are symptomatic, high possibility, high probability that it can be COVID. You isolate yourself. You isolate yourself properly from the rest of the members of the household and including the workplace. That's why you have to be at home. And if you need to go out, for testing. Since it's only mild, you don't need to be tested, no? Because it's only mild. There are recommendations in the Department of Health in terms of prioritization of testing, especially if the testing capacity has been overwhelmed. And these are the vulnerable population, the A2 and the A3 population. So in case that we need to be tested, when we need to prioritize the vulnerable population over the younger population and over those with only mild symptoms.
Last question, sir. I know marami pa po, but with the limit of time, we know that Dr. Solante is very busy. May mga meetings pa si sir. Sir, paano daw availability ng mga gamot po niyong ni-lecture kanina? Very important.
Okay, so I think these are all available, no? Except for the Nirmatrelvir, ritonavir combination. I don't know if it's available, but I've heard that it's already been given a CSP approval from the Philippine FDA. So all of these medications cannot be bought over the counter, no? That's one. It should be prescribed by your attending physician. And it can only be bought in the hospital. So there is proper monitoring and proper follow-up of your physician when you will be given these medications. Remember, these are all still an EUA, and we need to know if there are adverse events, and that's the reason why that strict monitoring is implemented based on the EUA approval coming from the Philippine FDA.
Okay, with that, sir, Dr. Solante, we would like to thank you for sharing us your time with us today. Sir, alam ko very busy kayo. Thank you for your time and your effort in helping us in battling this pandemic ever since it started in 2020, early 2020. And always stay healthy, sir. Para marami pa po kayong natulungan na pasyente at mga doktor na na-educate nyo. So, sir, maraming hanggang sa susunod, sir. Kasi, sir, ang dami pa talagang question, but napaka-limited na tayo. May mga nagtatanong na po ng part 2. So, sa mga nagtatanong or yung mga questions, we'll try our best. The PCP will talk about this. Sir, with that, thank you so much.
Thank you, Ginger. And thank you also to Danny. Bye-bye.
Okay. Sir, Ma'am Jel, mag-post na po tayo ng mga announcements natin. By the way, the PCP will be having its annual pre-Congress webinar series with the topic of COVID-19. So, makikita po nyo sa screening nyo ang invitation and the program. So, you could register with PCP. For any questions, you could contact us through our email and our other social media accounts. So please attend po kayo nito para ma-add po ang new information about COVID-19. And we know that COVID is really a very dynamic disease. Maraming mga pagbabago at maraming treatment na nangyayari po. So with that, I would like to thank you everyone for attending this first PCP Media Conference. Alam ko pong marami pa pong tanong na baka hindi nasagot. Pasensya na po because of the limit of time. But don't worry, you can reach us and follow us to our social media account and in our email. And we'll try our best to answer all your questions. So with that, maraming salamat. Magandang umaga. Mag-ingat po tayo. Yun nga po ang mga habilin ni Dr. Solante, na kahit vaccinated, hindi ibig sabihin na hindi na tayo magkakaroon ng COVID. Ang number 1 po pa rin is to practice social distancing at saka po hand washing and always wear our face mask and face shield and avoid crowded areas. At kung may mga lakad tayo na hindi naman ang importante, wag na po tayo masyadong lumabas ngayon with the surge. So, thank you so much and a good day until we meet again to our next PCP Media Conference. Maraming salamat. Thank you. Stay safe.